Hi, everyone. Thank you for spending some time with us today. My name's Bonni Goldstein. I'm a cannabis clinician in Los Angeles, and today I'm going to be talking about integrating cannabis into cancer care. I want to thank our sponsors, which are Realm of Caring and Leaf 411 and Goldstein Wellness as well, to bring you this information today. So let's get started. We have a lot to cover. And we're going to hold your questions until the end. So, what is the rationale for using cannabis when cancer is present? And it always comes down to the endocannabinoid system. Um, the endocannabinoid system consists of cannabinoid receptors, as you can see, these little, what look like blocks, endocannabinoids, which look like keys, and enzymes, which are not shown here, but that the enzyme's job is to make endocannabinoids and break them down. Endocannabinoids are made from healthy fat, so make sure you eat healthy fat. The whole reason we have this system is to promote homeostasis. And what that really means is all of our cells are talking to each other, and what we want is balanced messages going from one cell to another. We don't want panicked messages. We don't want the message of pain. We don't want the message of nausea. Of course, these are adaptive and they are good to have because they can indicate something is wrong. But when someone gets into chronic illness, when somebody is struggling with underlying genetic differences in their endocannabinoid system, which can happen, the system may not work real well. And it can lead to symptoms like what we see in our clinics, which is pain, nausea, not sleeping, just not feeling right, anxiety, depression, and then also a whole slew of other conditions that are taxing the endocannabinoid system, and the endocannabinoid system needs just a little boost to help maintain homeostasis. So the idea here is that we have this plant, and it's going to interact with this system. And the way it works is this is a sending cell on top, this yellow representation, presynaptic brain cell, sending messages in the form of chemicals, which are neurotransmitters from one cell to another. And when those messages are often they're overstimulatory, too much, excitatory messages, the receiving cell, the postsynaptic neuron, gets what they call perturbed and turns on the factory to make endocannabinoids. So you make them when you need them. And those endocannabinoids act like locks that fit into the key. So they travel in a backwards retrograde fashion and bind to the receptor. And when that key hits that lock, the message is sent to dial back for the most part. Put the brakes on that over messaging. And remember that over messaging could be pain, it could be nausea, it could be seizures, it could be anxiety, panic attack. It could be just dysregulated thought process. So this is a mechanism by which our body works to keep us in balance. The system itself is sometimes taxed, especially chronic sleep deprivation, chronic anxiety, chronic poor diet, not enough exercise. All of those things can help your endocannabinoid system function better. And so, just needless to say, this is a very key system, and you want it to be working well so that you feel well in that space of homeostasis. So this system is involved in the immune function, inflammation, pain signaling, appetite, mood, sleep, kind of everything that we do, that we are, but also in the face of cancer, it is involved in cell survival and cell death. It helps regulate, helping to kill cells that shouldn't be there and helping to heal cells that should be there and maintain survival of those cells. So when we think about what we see again in the clinic, it's often a function of one of these conditions or one of these symptoms or systems. Many tumors also express the endocannabinoid system, and they can have altered cannabinoid receptors, dysregulated endocannabinoid tone, or alterations in the enzymes that make endocannabinoids or break endocannabinoids. But if you think about an endocannabinoid system within that tumor cell, thinking about those keys and those locks, right? That gives us a target to try to kill. If it's sitting on the cancer cell, we can use that system to try to kill the cancer cell. And that's one of the ideas here. The endocannabinoid system is involved in cancer cell growth, as I've mentioned, cell death, as I've mentioned. Angiogenesis is when the cancers make their own blood vessels to feed themselves. My understanding is that once the cancer is the head of a ballpoint pen, the size of a head of a ballpoint pen, it is already making its own blood vessels. And there's foods that you can read about or watch videos on that starve, that have some starvation. They help kill and block this blood vessel growth. So cannabinoids can be anti-angiogenic, and there are also chemotherapies that also are anti-angiogenic, blocking the blood vessels. Metastasis is the spread, and cannabinoids have been shown, or the endocannabinoid system is involved in those messages, and cannabinoids from the plant may block those. And then also clearly involved in immune signaling and the type of immune cells that are looking at the tumor, that are in the tumor environment. And so we have strong clinical relevance for using cannabinoids for symptom management and potential anti-cancer effects. And we say potential because there have been very few human studies, a fair amount of data within the preclinical test tube and animal literature. So I'm starting off by just showing you this recent report that came out last year. You know, this got mixed reviews. A lot of people were kind of anti this study. But the researchers looked at over 10,000 studies on medical cannabis and cancer. They analyzed 39,000 data points, and they included preclinical, observational, which I'm going to show you some today, and clinical, which was very limited, just a few studies, meaning that we have very few studies of the effects of cancer in humans where we actually are driving the treatment, not just people taking cannabis. Oh, by the way, I'm using cannabis, and then we study them. It's we are giving you cannabis. And again, just very few. It's very disappointing. Anyway, instead of a typical meta-analysis where they take the studies and they pull out all the data and pull it all together to see if they can come up with a larger participant group, and that gives you more robust data. This actually looked at the natural language that was within the reports, and did the language, the study, was it supportive of the use of cannabis in cancer, not supportive, or was it unclear, inconclusive? And so what they found was the majority of published findings were supportive of symptom management. So pain, nausea, vomiting, appetite wasting. Wasting is when you just really can't keep the weight on. And what's interesting, though, is that this is not offered to people when they see their oncologist. Usually you have to bring it up. Sometimes a nurse will bring it up. Sometimes you're referred to pain clinic and they may talk about that, but it just makes me kind of sad because as you'll see, one of the first studies in 1975, there's evidence here that this might help somebody feel better. And normally for symptom management, it can be taken as needed, and it can be low dose, and it can incorporate THC, CBD, CBG, whatever. In my experience, in my practice, is very effective to help people through cancer treatment. Now, what about the anti-cancer effects? Well, the preclinical literature that they reviewed was supportive of the anti-cancer effects. But of course, That doesn't mean we know what we're doing. More research would really be very helpful. All right, so let's move on to symptom management. So here's that report that I mentioned. So this was the first report in the scientific literature in a very prestigious journal, New England Journal of Medicine, about the antiemetic effects of THC in patients getting cancer, chemotherapy. It was published in 75, and they saw a 70 to 80% efficacy. And it was interesting, they also reported that if the patient felt subjectively high during that time, there were no episodes of vomiting. So it was pretty effective, especially if you were feeling the effects. And this led to lots of studies in the 1980s. And so they also, at that time, developed two synthetic THC. It says cannabinoids. I should really change that to THC. So synthetic THC-like compounds that you take. It's a single compound as opposed to when using whole plant. It's got everything in it. But these drugs are effective. One of my mentors, Lester Grinspoon, Dr. Lester Grinspoon, had said at one point that when you look at the synthetic THC and you look at the natural, in any particular individual, if they had tried both, they always preferred the natural over the THC, the synthetic THC. And the reason is that the whole plant has other compounds that help balance out the effects, that entourage that we talk about. Now, in 2017, the National Academies of Science, Engineering, and Medicine put out a report. They had 16 cannabis experts who reviewed over 10,000 papers to see what do we know so far. So this is almost 9 years ago that the report was out. So remember, all the studies that they looked at were from before 2017. And we have almost a decade now of more studies. But anyway, they concluded that in adults with chemotherapy-induced nausea, vomiting, oral cannabinoids are effective antiemetics. And, it's still kind of sad that nobody tells patients this, right? All right, another really interesting study. This is from 1995, and you can see Dr. Meshulam, who, if you're not familiar, was basically considered the father of medical cannabis, has done a tremendous amount contribution to cannabis science. He formulated a delta 8 THC. If you're not familiar with delta 8 THC, it is an isomer of delta 9, whereas many cannabis plants have 19, 20% delta 9 THC. Most plants run between 0.1 and 1% delta 8 THC. So it occurs naturally in the plant, but in a very small amount. When you see products on the market that say delta 8, by definition, they're made semi-synthetically from CBD. The conversion process of CBD to the delta 8 is highly dependent in terms of whether or not this is a good product to use, is completely dependent on the process, what's being used, how it's being done. Because if you don't know what you're doing, you may end up with a product that has a fair amount of delta 8 and then a whole bunch of contaminants that could potentially be dangerous. That's why there's this big argument to get intoxicating hemp off the market. But delta 8 itself occurs naturally in the plant and is a good compound, not a bad compound. It is weaker than delta 9. But as you'll see in this report, Dr. Meshulam, who's a chemist, knows what he's doing, and he created a 99% pure delta 8 THC to give to children who were fighting cancer, who were on various chemotherapy agents that were highly nauseating and caused a lot of vomiting. So they treated 8 kids between the ages of 3 and 13. Total number of doses over the entire 8 months was 480 doses. So it's quite a few. And what they did was they gave the dose 2 hours before chemo and then every 6 hours for 24 hours. And they completely eliminated vomiting in these patients without any side effects. The kids were not under the influence. And, it's really sad that nobody took this and ran with it. And, Dr. Meshulam said the same thing about his research on CBD for seizures. In the 80s, he kind of figured out that CBD worked, and there was no progression forward. And I guess remember the times back then. All right, and so how do these compounds work? So THC works through your type 1 cannabinoid receptor, so it binds like a lock and it turns off the nausea message in the brainstem vomiting center. You can use THC alone. It can be very effective, and in my experience, you don't need high doses. Can be combined with other cannabinoids, which I'm going to talk about in a second because they have different mechanisms. And one thing that is advantageous for THC is it could be vaped or smoked to get immediate onset to help somebody who's really struggling. CBDA and THCA are both potent antiemetics in the animal literature, and high doses are not needed. CBDA works through serotonin receptors, and THCA is thought to work through the type 1 cannabinoid receptor, but maybe through other mechanisms as well. And we have very little human data, other than I think, anecdotal. I have used CBDA in some patients and THCA as well. And for some patients, it can work very well, especially if they are someone who really doesn't like the effect of THC or only gets, has to be impaired in order to get the anti-nausea. But in general, most people are using THC in my experience, with just some using these others. What about poor appetite and weight loss? Well, studies show that there can be some benefit here, but be aware that the overall studies are low quality, and most tested synthetic cannabinoids. In the studies, there's like the dosing is all over the place. Who could be included is a little bit all over the place. So it's hard to make robust conclusions from any of that. Clinically, though, what do people tell us? And what they tell us is that food, they're interested in food again. They have an appetite. In terms of weight loss or weight gain, I personally have what I've seen, except in very young children who, if you can get them to stop having nausea and vomiting, they are growing quicker anyway. So they will grow. It obviously, chemotherapy can slow down the growth in young children. But what I've seen mostly is it slows or stabilizes weight loss and also increases the enjoyment of food. So somebody says, oh, I can actually taste food again and it tastes good. THC seems to be the most effective. That should say CBDA, THCA, CBN, and CBG all may be effective, but remember we have no studies in humans. And then CBD, be aware that higher doses of CBD may actually decrease appetite. This comes from the epilepsy literature, where patients that were using very high doses of CBD to control seizures had lowered appetite and weight loss as part of their side effect profile. I have had patients who I've treated with high dose CBD who have cancer, and if we think that it's really affecting their appetite, we'll just lower the dose by 10% and kind of keep chunking away at it. And usually just a little bit lower will reestablish, even in the face of THC. So just be aware of that one. All right, cancer pain. 30 to 50% of cancer patients experience moderate to severe pain. There's different types of pain. So nociceptive pain is caused by the actual presence of a tumor and the damage it's doing in the area where it is. Neuropathic pain is when you have nerve pain, either directly affected by the tumor, like nerve, it's pinching on the nerve or pushing on a nerve, or from chemotherapy. And then inflammatory pain is when tumor or the tissues around are releasing chemicals called cytokines, which can be pro-inflammatory. And then mixed pain, which is very common, 2 or more of the above. Cancer pain can be challenging to treat. Opioids are the mainstay. And about 50% of cancer patients are suspected to be undertreated for pain based on some of the latest data. This is a report that came out in 2018 from Israel. They looked at almost 3,000 cancer patients using medical cannabis for over 6 months. And they surveyed them, and 1,211 responded. And Interesting number, 95.9% reported improvements. This is kind of what I see in my practice, so it doesn't surprise me, but I think some people are surprised. If you look at this graph here, what you're seeing in this bar graph is across the bottom, the pain intensity. So 0 out of 10 pain, 5 out of 10 pain, 10 out of 10 pain. How many patients are listed here on the left? And then blue is before treatment and orange is after 6 months of cannabis treatment. And so what you see, I'm going to start at 10 out of 10. So before cannabis, 253 of these surveyed patients had 10 out of 10 pain. And after 6 months on cannabis, only 11 report 10 out of 10 pain. Similar numbers, 9 out of 10 pain and 8 out of 10 pain. Where did these patients go? Like, where did they move to in terms of did they go from 10 to 0? Well, some of them did, right? So what we see is 238 of these patients said, I don't have any pain before medical cannabis, but that rises to almost by 100, about 315, up to 315 patients went from having some pain to in that category of no pain. And what you see then is between 0 and 5, those numbers go up, but they go up because these patients are moving down on the pain scale. So very encouraging results. It is what I see in my practice. Overall symptoms, in just looking at everything that cancer patients have to deal with, anxiety, sleep, appetite, nausea, vomiting, pain, mood. This study showed that there were benefits in all of those aspects of symptoms within 4 months of using medical cannabis. So this was 1,120 cancer patients. They reported biggest improvement was in nausea and vomiting, and the smallest improvement was with fatigue. And by the way, this number here, p less than 0.001, if you're not familiar, p values just kind of tell you, could this be due to chance? And so the lower the number, the less likely it is due to chance. And our cutoff is kind of like 0.05. So basically that represents 5%. We allow for, that 5% leeway. And so here it is in terms of if it's over 5%, it's probably due to chance that we found these results, which means that the drug didn't work or the intervention didn't work, right? And so anyway, it's very interesting results that we see these numbers over and over. And if you talk to someone who is using cannabis during their cancer journey, they often will tell you it is just, they don't know how they would do it without. All right, let's talk about the anti-cancer effects. And as I alluded to earlier, cannabinoids in the preclinical arena, meaning animal and test tube studies, inhibit cancer cell proliferation and growth, cause cancer cell apoptosis, that's the programmed cell death, or for lack of a better term, cell suicide, cause cancer stem cell death. So cancer stem cells, I haven't mentioned, these are, all cancer cells are not exactly at the same level of maturity. Cancer stem cells are immature, and they are particularly nasty because they're difficult to kill. And they often are the culprit behind reoccurrence of cancer. And even though someone may be determined to have no evidence of disease, these are the cells that can still lurk and come back. And there are some studies showing that cannabinoids can, again, preclinically kill cancer stem cells. I've already mentioned metastasis or spread of cancer and angiogenesis. Remember the blood vessel growth. Cannabinoids inhibit these processes. They slow them down or stop them. Cannabinoids also, because they do affect your immune cells, have been found in the lab to induce anti-tumor immunity, meaning help boost your immunity towards anti-cancer effects, and then also enhance some chemotherapies. Not every chemotherapy has been tested this way, but there can be synergy between the cannabinoids and the chemotherapy, meaning resulting in a better outcome. And the same thing with radiation. There's some evidence that, for instance, CBD makes cancer cells more susceptible to the killing effect of radiation. Now we have a lot of unknowns though. So which cannabinoids are most effective for different cancers? Which terpenes are most effective for different cancers? Remember, terpenes are the essential oils in the plant that can also contribute to benefits. What other compounds in the plant are effective? This is a plant, the plant's filled with compounds. Last number I heard is in the high hundreds, and I've heard some experts say they wouldn't be surprised if we discover thousands of compounds. We still don't know everything. What dose should a patient take? How long should cannabis treatment last? Which chemotherapies are the most synergistic, which are not compatible? And what about cannabinoid drug interactions? We do have some handle on this potential cannabinoid drug interactions, because if we understand how the drugs are metabolized, we can compare with cannabinoids and try to understand the mechanism there. But still, this is a tremendous amount of research that remains to be done. I certainly hope that we can get it done. In the literature, this is the list of cancers that have shown some evidence of being sensitive to cannabis killing. And so it's quite a list, includes some very common cancers. There are a lot of cancers that haven't been looked at. So, but with this list, we do see a tremendous potential here to try to get better outcomes. What about the human clinical data? Well, I am so sorry to say that, this is it for the slide. It is really depressing to me because I've been doing this 18 years now, and you would think there would be more research, but no. So anyway, the strongest signaling for human response is in glioblastoma or recurrent glioblastoma. THC has been looked at. The combination of THC and CBD has been looked at alongside chemotherapy. In general, treatment was very well tolerated, so I wouldn't expect otherwise. Cannabis is generally well tolerated, even in high doses. One small study suggested longer survival at 1 year, and this is a study that looked at the standard chemo, temozolomide by itself versus temozolomide plus CBD and THC in about a 1-to-1 ratio. And the study showed that there was longer survival for those patients who did the combination versus just the chemo alone. Again, the numbers are very small. And so to me, of course, why wouldn't we continue to look? This is a horrific cancer, and we have nothing else. We definitely have to think out of the box here. Certainly larger studies are needed. I have treated a fair number of patients with glioblastoma, also astrocytoma, which is I see in pediatric patients often. And there's no question in my mind that there seems to be some advantage, and parents are reporting, the doctors are surprised because the scans are stable, or the doctors are surprised because, we had a poor prognosis and here we are still alive 2 years later. It's just, again, we don't have a lot to go on, which makes it challenging for the clinician to know exactly the best way to treat cancer. I don't have any problem treating somebody with an advanced cancer in general. And sometimes I have not been able to take on patients because of where they live, but also that immunotherapy has not been understood. And we're going to get to that. All right, so what about the published clinical cases? So this is interesting. This is from 2011. It's a report by a neurosurgeon and some others on 2 pediatric patients who both, they didn't know each other. They're 2 separate patients with pilocytic astrocytoma, which is a brain tumor. And each of these patients underwent a tumor resection where they went in to take the tumor out, and they were left with a little residual tumor. They did not get radiation or chemotherapy. These tumors were just being watched and monitored with MRI. And in one patient, there was stability that showed wasn't growing, I think after a year or so, and then the other one showed some slight tumor growth. And what's interesting is they decided just to kind of keep watching. And what they saw over time was regression of these tumors over 3 years, which coincided with the use of inhaled cannabis. Now, these were pediatric patients, so they were teenagers during this 3 year period, and both had decided to use cannabis that way. And so the authors just kind of floated the idea that what we call spontaneous regression, because some of these tumors do have that, whereas they just go away on their own. So the question is it that or is it cannabis? And they pose this thought here: one factor that has not been previously considered as a cause for spontaneous tumor regression is the use of cannabis in both our patients. Cannabis use coincided with the regression of the tumor, and one must question if it had a role in regression. So I showed you all of the things that cannabinoids can do to cancer cells, and its growth and its blood vessels and so on and so forth. And how do we not question this, right? Did these patients get better because of inhaled cannabis, or was it coincidental? And this is why we need research. This is a very interesting report: a 14-year-old with aggressive leukemia that had a high risk chromosome mutation called the Philadelphia chromosome with a poor prognosis. And the child went through very aggressive chemo, radiation, and bone marrow transplantation, and did not get well. And at 34 months, they had decided that this was a treatment failure, and they basically told the parents, there's not much else we can do, so we're going to send you home. The parents decided, or somebody decided in the team, to try the FICO oil, full extract cannabis oil, sometimes called Rick Simpson oil. It's just thick, concentrated, high potency oil that some people claim to kill cancer. And so they gave this child this oil, and there was a rapid dose-dependent correlation response. And I'm going to show you the graphs here. So this patient had a central line, and remember, for leukemia, you don't have to do a scan. You can just draw blood and look at the cancer cells in the bloodstream. We call those blast cells, and that's what this patient had. You're not supposed to have any blasts. And she had 228,000, this is per thousands on day 0. It really turns your blood to sludge. It's very dangerous. It can cause a stroke. And so she was in a very precarious position. And so she goes home, she gets her cannabis oil and her counts. And by the way, they're following along. The researchers are drawing blood from the central line so that they can look and see what's happening in response to the cannabis treatment. So she goes to 272,000. Day 5, she gets to 374,000, and which is, very dangerous. And then all of a sudden it starts to go down. And as you can see, and by the way, this is dosing next to the day: 0.02 ml, 0.05 ml, 0.66 ml, 0.1 ml. And I'm not sure, I think that's total per day. It might be per dose. Anyway, she was getting apparently every 8 hours. And you can see here clearly what we call a dose response curve. So the numbers are coming down. There's no other treatment. She's just getting cannabis. Even the first 5 days of her cannabis journey, it's still climbing. And then all of a sudden, there's a downturn. And so the next one shows you day 18 through day 39. Well, on day 18, it's starting to climb. Why is it climbing? Well, she had finished that first syringe and they went to the second syringe. And remember, this was in the days when nobody knew how many milligrams were in those syringes. And they notice, okay, her numbers are climbing, and they decide on day 27, it looks like they backed up and started low dose again. And then on day 27, they were back up at a higher dose, and there was this precipitous drop. So we have a second dose response in the same patient who's still not on any other new treatment for cancer. And as you can see, at day 39, it's like 300 cells from 228,000 with a peak of 374,000. And then it stays down low. and that's for about a week there. And then it starts to climb. And this correlated with her getting a line infection. She ended up in the hospital, and they were only giving the dosing 1 to 2 times a day rather than 3 times a day. And then when they changed it to 3 times a day, lo and behold, we see another dose response curve. And unfortunately, around day 78, she got very ill with a bowel perforation and passed away. But what this shows us is how much you take matters and how often you take it. It's very important. It's not just some cannabis oil. This was not attributable to the phenomenon of a spontaneous remission because we got 3 dose response curves. And then, as I mentioned, how much and how often matters. This is a report that came out of the UK using a synthetic CBD over 4 years and 119 cancer patients. They all had different types of tumors. They report a clinical response in 92%, but of course there's limitations. It's observational. We don't know what else patients were taking. They all had different tumors, so it's hard to compare. But they did see a reduction in circulating tumor cells. That is a test that some clinicians order on their patients to see how many circulating tumor cells or what cells are floating around in the bloodstream. And also they did see reduction in tumor size. There were no side effects reported in this population. Some patients switched to the natural oils from a synthetic CBD to whole plant cannabis and did worse. And one wonders, were they just not doing great anyway? It's hard to know. And certainly that would be a great study, synthetic CBD versus natural, right? To be able to see what the cancers are doing. And then this is a report of an 80-year-old male with lung adenocarcinoma. He declined chemo and radiation. He decided to self-medicate with CBD and took 600 milligrams a day of an oral oil, and radiographic tumor regression was documented. And again, no treatment at all during the period that he was on CBD. And what you see here on the left top is this tumor in his lungs. So these are his lungs here. So he's laying kind of flat on his back. Here's his vertebra. And you're seeing a slice. And so here you see tumor in the lung. And here you see these very large lymph nodes that are lighting up here. And then I'm sorry, I don't remember how long it was, but afterwards what you see is you see significant shrinkage of the tumor in the lungs. And also notice those lymph nodes. That's a big difference, right? Those big white globs right there are swollen, infiltrated lymph nodes. And here you can barely see anything. So something to be said there as well, right? So again, a bigger study would be better. All right, we're going to move on to immunotherapy. So we have very mixed and inconclusive evidence. Nivolumab is a checkpoint inhibitor type immunotherapy. And there was the first study that came out on immunotherapy being used in the clinic by patients also using cannabis. It scared the heck out of all of us practicing cannabis medicine. What they showed was that the response rate to this particular drug was 37.5% in people without cannabis in their regimen and much lower in people who were using cannabis, meaning it lowered your response rate, ? So now we're like, ooh, don't take cannabis with immunotherapy, but we have really not a lot of science to hang our hats on. And then another study comes out the next year that says in 102 patients using these different checkpoint inhibitors, I think there were 5 different ones that they looked at, cannabis use was associated with a shorter time to tumor progression. So the tumors were progressing quicker in cannabis using patients, and also a lower overall survival. So that kind of was like, okay, I don't want to make somebody worse. Remember, our oath is do no harm. So for me, if you were on immunotherapy, I was not necessarily going to treat you unless there was some compelling reason to do so. And then we had another study that came out that said that, and they looked specifically at non-small cell lung cancer and a particular treatment called pembrolizumab, which is Keytruda, which you may recognize that name. No significant difference in progression, and survival differences were not statistically significant. And so everybody was a little relieved with that. And then this report came out, this was a systematic review of the effects of cannabis in patients with and without cancer, meaning what do the cannabinoids do to the patient's immune system, right? We don't have a lot of studies on immunotherapy, but immunotherapy harnesses your immune system. So let's look at what is happening in the immune system. And so they found no meaningful changes in immune markers with cannabis, no clear evidence that cannabis interferes with checkpoint inhibitors, but of course they called for more studies. Now we're just going to move to a couple studies on survival. So there were this particular report looked at people in palliative cancer care, 9,419 advanced cancer patients. They compared their survival in patients that had no THC, those who had low dose THC, defined as under 4.7 milligram per day, and higher dose THC defined as greater than 4.7 milligram per day. And what they found was survival was significantly longer in patients receiving the higher doses of THC. So in patients surviving 7 to 100 days after enrollment in the palliative care program, THC was associated with a 40-day longer median survival versus no THC, 25 days. Now, one might say, well, who wants to live longer if you're dying? But certainly if you're suffering, I would not wish that on you. But if you are comfortable, cannabis is helping you stay comfortable as you transition. To me, more time with family is better if my loved one is not suffering. And I leave that to everybody to decide for their own family. I'm not going to, what works for me may not work for you, but especially with pediatric patients, the parents cherish every extra day. And there's no question. I've had a number of patients where the oncologists withdrew treatment and the child lived much longer than what was expected. In fact, in one case, a child, the oncologist kept calling the mother because she kept waiting, because she had sent the child home thinking that he was going to pass very quickly. And I think he had another 6 weeks with his family, and he was not suffering. And they were able to, do a make-a-wish and that kind of thing. So anyway, it's terrible to talk about this, but at the same time, there appears to be some benefit in terms of survival. And here's another report. This one comes from Thailand, and they looked at patients with advanced cholangiocarcinoma, bile duct cancer, or hepatocellular cancer, liver cancer. And they compared 404 standard palliative care patients with 87 who received medical cannabis treatment. And the standard treatment median survival time was 0.8 of a month. Cannabis treatment median survival was 5.66, and it seems very striking difference, right? And it seems to be, but remember too, there were some limitations here, and people go into palliative care or hospice care at, depending on when somebody might recommend that. Some people are earlier, some people are, and not as sick, and some people, become very sick and then go in. So they started the survival count was when you enrolled. So remember, there was no standard of kind of level of illness. So, but I think there's a signal there for sure, and it definitely corresponds to what we're seeing in some patients using cannabis in palliative care. All right, this is the last category here. So drug interactions, CBD can definitely interfere with some drugs. CBD is well known to be metabolized at and interact with a family of enzymes that work to break down drugs in our body. And that's called the cytochrome P450 system. And CBD is metabolized at one of the members of this family of enzymes, where 60% of other drugs are also metabolized. So what you'll see is a competition for the enzyme, and CBD can inhibit that enzyme from working. And that means the other drug that's relying on that enzyme is not interfacing with the enzyme, meaning it starts to build up, especially if you're taking the medication on a regular basis. And then you can end up with higher levels in the bloodstream, which can cause more side effects. CBD can also activate some enzymes to work a little bit faster, breaking down that drug quicker. And then that drug is cleared out of your body quicker, and then you have lower levels, which may not be as effective. So knowing the list of medications and which cannabinoids are being used is very, very important. The effects seem to be dose dependent according to the scientific literature, meaning higher doses of CBD may have higher risk of drug interactions. And I just cannot stress this enough. Do not start or stop cannabinoids during a cancer journey without medical supervision. I know a lot of people do it, but I just worry about those people end up in the hospital with, terrible chemo side effects, and nobody's thinking about, could it be the cannabinoids? And you can still reap the benefits of cannabinoids, just maybe at a lower dose. It's better to work with someone who has some knowledge. I am a fan of telling the oncologists about cannabis. I want them to see what cannabis does for their patients, but I want them to see the best results, and the best results will always come with medical supervision. And so I do think it's important for cancer patients to have somebody involved. Yep. All right. Thank you so much. This is our upcoming webinar. Schedule all free, all on Thursdays. We have one in April on cannabis and dementia, April 9th. We have one in May 7th on cannabis for anxiety, benefits, risks, and tips for success. And then June 4th, we've got minor cannabinoids, current evidence, and patient reports. And remember, these are going to be posted on our various websites. And I just want to say again, you don't need to do this alone. I started my company, Goldstein Wellness, to get more doctors on board who can help more patients. So we have doctors learning and helping patients. We have patients interfacing with doctors. So if you need help, reach out to us. And we're partnering with Realm of Caring and Leaf 411 to be able to provide the best information, the truth about cannabis, when it is indicated, when it is not, when it can help you, and what to think about and how to avoid drug interactions. So please reach out. We are very happy to help you. All right, everybody have a great night. Thanks. Bye-bye.